External anatomy of the eye. The eyes are fascinating, really. If you take a little bit of time to kind of think through how the image is actually presented and how that's transmitted to the brain and how we're able to process that, the eye really is an incredible part of our body. And as far as the external anatomy of the eye, there's a couple different things that should be of mention. So you have lacrimal gland and excretory ducts. This is what is responsible for some of the tearing. You have a lacrimal papilla, and then lacrimal sac, and that is in the corner of the eye towards the nose, and you have one bilaterally, the lacrimal sac, that ends up leading to what is known as lacrimal lake. And then you have drainage through the nasolacrimal duct down to your nose. And this is why anytime you are crying, your nose starts to run, because all of that fluid starts to pull over into the lacrimal sac and lacrimal lake. And then it drains into the nasolacrimal duct and then out through the nares on both sides. Some external anatomy of the eye continued. It is protected by bones, our ocular orbit, which is what is responsible for protecting the eye. The orbit is padded with subcu tissue and subcu fat, and this is meant to cushion and protect the eye from additional injury or any type of insult that may occur. Movement of the eyes are controlled by 6 different extraocular muscles, and this allows us to look in various directions. This is how we're able to look up, down, left, and right, etc. And then we have 2 movable skins of fold, or folds of skin, I'm sorry, and these are your eyelids, and this is what protects the eyes from the environment. So a couple different things here that we should talk about, and we'll look at these a little bit more closely. We're going to go through all the anatomy as far as the cornea, the iris, the lens, etc. But basically, the optic nerve at the back is what I want to kind of show. The optic nerve is what is going to allow us to process the message into the brain, so that our brain can take that image and then come back with a depiction of what it is, or a identification of what we are looking at. And it is really interesting if you look into this and read up on how this all kind of comes to be. So external anatomy of the eyelash functions as a sensor, and that causes rapid closure of the eyelids if there's any type of foreign body that is approaching the eyes. And then there are glands that secrete an oily substance called sebum onto the eyelids to keep them soft and pliable. So we hopefully have sebum, and we're able to do that. Otherwise, you end up getting like crustaceans to the eyes. They may become itchy. They may become red and inflamed, and we certainly don't want that to happen. And those glands that secrete those oils is what prevents that from occurring under normal conditions. The external anatomy of the eye here, the membrane, the conjunctiva, this is the layer that covers and protects the exposed surface of the eye, and we're going to look at this a little bit more in depth when we talk about conjunctivitis. Each of the eyes have the lacrimal apparatus that we've already talked about, and that's what is going to manufacture and store tears. And those are manufactured in those lacrimal glands, and they spread across the eye where they drain through the lacrimal ducts and into the nose, as we've already talked about. So pretty interesting how that actually works. The globe has 2 fluid-filled cavities, and we're going to break these down. So we'll spend a little bit of time on this particular slide. So 2 cavities, and they both have fluid in them. We'll talk about the different fluids that are in there. The posterior cavity is obviously the back portion. It's the portion of the eye behind the lens, and that contains vitreous humor. And vitreous humor is a clear jelly-like fluid that fills that entire vitreous cavity. And then the anterior cavity is the portion of the eye in front of the lens, and that contains aqueous humor. So the 2 different fluids that we are talking about, aqueous humor and vitreous humor. If we look at the eye here, and this is kind of a lateral picture, looking at things, if we find our cornea, the cornea right here, this is going to be that clear outer portion of the eye focusing system, and it's on the front of the eye. So things kind of come in here, and that's what allows the eyes to start focusing the image that is coming in originally. We jump up here to the iris that you're probably most familiar with. is the colored portion of the eye, and that regulates the amount of light that is coming into the eye. So that's pretty interesting. And this is what gives you the green or the blue or the brown, whatever it is. That is where your iris is at, and that is responsible for controlling the amount of light that is coming in. When we look at the lens, and the lens, a lot of people will refer to as the pupil, but the lens itself is a clear part of the eye behind the iris. So it sits just behind the iris a little bit, and it helps to focus that light or an image on the retina. So the macula, when we are looking here, and you're not going to be able to see this unless you're looking through a scope, looking into the eye itself. But the macula, if you are looking into somebody's eyes with instrumentation, you're going to be able to see in theory. And I say in theory very specifically because unless the eyes are dilated, you're not really able to see this all that well. I remember when I was in NP school and we had to do eye exams and we had to be signed off by a physician to do that. One of the ER docs was the physician that I had asked or requested to sign off on my eye exam. And I remember going through the entire eye exam, and the physician asked me, "Did you actually see all of that stuff?" And I was honest, and I said no. And he goes, "Well, that's good. I'm glad that you're honest with me because I know you didn't see it. None of us can see it. That's why they dilate your eyes when you go in for an eye exam." So even the physicians in the emergency department, now an ophthalmologist may be a little bit different because they're used to looking at that all the time. But if you're not used to looking at this, which we're certainly not, in paramedicine and even in the emergency department, they're not really good at looking at eyes, to be totally honest with you. They're not going to be able to see some of these things. But the macula is what I'm talking about right now. That's a small area in the retina that allows for central vision. And that is actually in the center of the retina. And that is what allows for the central vision. So if we're talking about central vision versus peripheral vision, the central vision is the macula. The optic nerve is the largest sensory nerve of the eye, and it carries the impulse from sight from the retina to the brain. The pupil, which everybody is familiar with, we look at those as far as like anoxic brain injuries and periods of overdose, those types of things. It is the opening at the center of the iris. The iris, as we've already kind of talked about, it adjusts the size of the pupil and controls the amount of light that can enter the eye. So we know that it's the colored part of the eye. We've already talked about that, but that's what allows for the dilation and the constriction of the pupil. It's all kind of controlled by the iris, if you will. And then we have the retina. And the retina we talked about just briefly. It's kind of back here with the macula on the posterior portion of the eye. It is a light-sensitive tissue at the back of the eye, and it converts light into electrical impulses that are then sent to the brain through the optic nerve. And then the vitreous gel that we've already talked about, this is a transparent, colorless mass that fills the 2/3 portion behind the eyeball between the lens and the retina itself. So believe this or not, I've actually seen aqueous and vitreous humor on the ground following a motorcycle crash. It was pretty interesting to see that. And to be totally honest with you, eyes are one thing that I'm not real good at. So I hope to never see anything like that again. But we all have our breaking point, and eye injuries are probably one of mine. So it was unfortunate that I had to see that, but we in fact did. All right, the innermost layer, the retina, the middle layer is called the choroid, and then the outermost layer is called the sclera. The sclera is going to be that tough, fibrous, protective area. And this is what is known as the whites of the eyes. So when you're looking at this, the whitest portion here is going to be the sclera. And then cornea is transparent, and it's a curved portion of the sclera and allows light to pass into the eye and onto the retina. So I think that there's a misconception a little bit that everything happens directly here, and that is not necessarily the case. So the cornea itself allows some of the light to go in, it allows that image to hit the macula, and then that information to be transferred down to the optic nerve so that your brain can produce an image. So it is really kind of the entire thing that is working to get you the image that you're looking for. The choroid is highly vascular tissue. It provides nutrients and tissues to the eyes, contains the iris and the pupil. And then the iris, which we've talked about, is that colored portion of the eye, and it controls the size of the pupil. So that is the reasoning for having the iris here that surrounds the pupil. It's the iris that actually is pulling back, causing pupillary dilation, or it's the iris that is allowing for pupillary constriction. It is all controlled by the iris itself. And it is the choroid is what controls all that. The vasculature, the arteries and veins, and all of the different vasculature that controls that comes from the choroid itself. Central vision, we talked about that as far as the macula. This is behind the pupil and the lens, and it focuses incoming light onto the retina itself. And then there are muscles, ciliary muscles, that surround the lens, and this changes the shape of the lens to focus the incoming image. The retina contains nerve endings and receives and interprets incoming images so that we can see basically what we are looking at. This would be what the example would be if you're looking through a scope into somebody's eye. The fovea is one of the things that we are trained to identify, and we should be able to call that out on an eye exam. And the fovea is responsible for a very sharp central vision, also known as foveal vision. And this is necessary in humans if they're trying to drive, reading, any activity where visual detail is going to be primarily important, then we want that foveal vision to be intact. So if you're looking at somebody's eye through a scope, we should be finding that fovea. You should be able to see the optic nerve. And then from there are a couple other things that we should be looking for. And again, I just remember as far as like memorizing that sheet, going through the eye exams when I was in school, not knowing that I've ever actually seen the fovea because I've never really looked at anybody's eyes that have been dilated. The retina contains two types of light sensing receptors. We have both our rods and our cones. Remember that rods are effective in dim light, and they do not see color. And then the cones are effective in bright light, and they do perceive color. So if you have somebody that is color blind, then they do not have the cones that they need in order to be able to perceive that color. Chemical changes send impulses to the optic nerve in the brain, where the image is then interpreted. So again, very interesting how it all takes place. Some conditions of the eye. So this is probably more important than you knowing how the eye necessarily works. These are things that hopefully people don't call 911 for, but I know that, they call for crazier things. So it is possible that you end up getting a call for something along these lines. And even outside of work and outside of EMS, if you have a child or a family member that has one of these conditions, hopefully you'll understand what it is and what needs to be done to hopefully try to control or minimize it. So one of the conditions that we'll talk about here is a stye, and that is also known as an external hordeolum. This is an infection of the eyelid itself. So what ends up happening here is they get a blockage of the oil glands that are associated with the eyelids or the eyelash. I'm sorry, you can see down here the eyelashes. Remember, we had that sebum, and that is that oily substance that provides lubrication here to keep things from kind of crusting over. If one of those ends up getting blocked, those eyelashes become inflamed and you have a blockage, and that is what a hordeolum is. So it is a inflammation that is located at the lash line, and it is noticeable because you'll be able to see that it is a small pustule or lump. It resolves when that blockage is relieved, and most of the time you're going to be able to get this to open up and relieve just through warm compresses. So if you're ever in a situation where you have one of these and you don't have an urgent care, you don't have anybody that can look at your eye for you, always start off with warm compresses. Try to get them as warm as you possibly can. Put them over that inflamed area. That will allow for additional swelling in hopes that that ruptures or that blockage kind of opens back up. And then you can end up getting placed on topical antibiotics if need be. So the external hordeolum, infection of the gland of the eyelid, Most of the time, these are caused by staph aureus. So it is a staph infection. And because of that, you'll have to be put on particular antibiotics that will help fight off staph. Common symptoms of this are going to be redness and swelling of the eyelid. And the differential characteristic is it is at the lash line. That's what we're actually looking for there for a hordeolum. Another one is called a chalazion, and this is an internal hordeolum. So a chalazion is inflammation or an infection of the meibomian glands and the tarsal plate of the eyelid. So again, it's the same concept as far as one of the glands being blocked. The meibomian glands produce fluid that lubricates the eye, and you'll see that this is going to be a red tender lump in the eyelid or on the margin. So conversely, when we're talking about the hordeolum, that is on the edge. This is not necessarily on the edge. You can see that it's down here more on the eyelid or more so in the margin. The treatment is going to be similar to that of a stire or hordeolum, which is going to be a warm compress initially, and it may also require antibiotics. So slowly, these are going to end up forming when that gland becomes blocked. These are going to be painful a lot of times, but after a little bit of time, once that swelling starts to come down, or certainly after you end up giving them a warm compress, maybe it starts to relieve a little bit, or after it ruptures, there should not be pain associated with it at that point because all of the inflammation is starting to go away. Conjunctivitis, infection or an inflammation of the conjunctiva. There's different types of conjunctivitis. Bacterial conjunctivitis is one that you're probably most familiar with. We commonly refer to that as pink eye. This could be caused by a bacterial infection or a viral infection, and the treatment is going to be based on symptoms. So maybe allergy related. In some situations, so you can try antihistamines. These can be kind of difficult to tell if it is an allergy type situation or if it's a bacterial type infection. Certainly, if we're talking about somebody that has bacterial conjunctivitis or pink eye, it is transmissible. So we try to keep people home from work or home from school in the event that we think that they have pink eye. It's just something to think about there because we don't want to spread this around. It is limited to the conjunctiva. The cornea is clear itself. Most of the time, these are going to be red and itching, and they're going to tear more than usual. And the treatment for these conditions is going to be topical antibiotics. The other kind of thing that you can see here is basically all the purulent or the pus that's kind of surrounding the eye. It's not necessarily pus, but it's all the drainage that is there. And it's basically that bacteria that is starting to come out, which is why this individual here would need a topical antibiotic to help relieve that. Herpes simplex virus, HSV keratitis. This is going to be an infection and inflammation of the cornea caused by herpes simplex virus. You can see here they end up doing this under fluorescein stain, and then they look at this with a slits lamp. So that stain picks up the herpes simplex virus. You can see the orange arrow kind of picking this up here, and that is your keratitis. So that is an infection and inflammation of the cornea. Frequent cause of corneal blindness, and it may require corneal transplantation. These individuals, if they have this, are going to have pain, photophobia, so they're light sensitive, blurry vision, tearing, and then erythema or redness. So all of this green here is basically just the stain that they put in there to try to figure out what is going on with the eye itself. They carry in the emergency department, certainly in the pharmacy, something called vidarabine drops. And these are drops that are given immediately after birth to protect the neonate or the newly born from HSV, because we know that HSV can lead to scarring and blindness in individuals. And that's basically what we're looking at here. Although this is an older person, that's why they end up doing the eye drops frequently after birth. Herpes zosters. Herpes zoster or shingles can affect the eye. This is what it would look like in an individual, this picture down here on the right-hand side. So that's herpes zosters or shingles that can affect the eye. And the virus spreads along the first division of the trigeminal nerve. So what you are looking at here on the left side, tri meaning three, this is your trigeminal nerve, and there are three different branches: the top, the second, and then the third branch. So herpes zoster travels along this first branch of the trigeminal nerve, and that is where you are going to see this. If it was on that second branch, it would be down here more on the cheek. And if it was the third branch, then it would be down on the jawline, but it doesn't normally follow that dermatome. It is up into that first division of the trigeminal nerve, and that's what they're trying to show you here. Damage can result to the eye itself, the ulcer, or similar lesion, or the cornea. While I have this up, I'll talk about trigeminal neuralgia just very briefly. That is a condition where this trigeminal nerve becomes inflamed. It has an increased frequency for pain. Individuals that have experienced this talk about it being completely unbearable. And actually, there's quite a bit of documented case where individuals could no longer take the pain and then turn to suicide to get rid of it. So trigeminal neuralgia is definitely not something that you want. And a lot of times it kind of goes hand in hand with the herpes zosters or the shingles of the first division of the trigeminal nerve. Let me talk just briefly here about ulcerations, and then we'll take a break and we'll come back in a few minutes. Corneal ulcerations, unfortunately, I've had this personally. Not a good feeling. It takes a couple days for this to resolve itself, and they're very, very painful. If you've ever had a corneal ulceration, you know exactly what I'm talking about. So again, this is fluorescein stained and looked at under a slits lamp, and you can see the ulceration right here. That is what we're looking at. You can kind of see under the black light or the slits lamp all of that other staining that is present. That's what you're looking at. So corneal ulcers, an infection of the cornea by an infectious agent, and it breaks through the epithelial layer of the cornea. It is very painful. Serious and sight-threatening infection can cause that. Painful red eye, tearing, and photophobia. This is a situation where you cannot look at lights. You need to have like a moist compress or something over your eye. Certainly sunglasses on. You're not going to be wanting to be outside looking at the sunlight. I can tell you that. Viral infections treated differently from bacterial infections, which goes without saying. With the bacterial infections, obviously, you could use an antibiotic, and with viral infections, you're not going to be able to. But evaluation by an ophthalmologist in these situations is critical. So please, if you take one thing away from the presentation today, if it is involving your eyes, do not mess with it. Make sure that you seek proper treatment and you see an ophthalmologist. All right. Let's take a 10-minute break here. I'm going to pause the video and we'll come back and we'll talk about periorbital cellulitis as we come back. Thank you. Okay, welcome back. We're going to pick back up here with periorbital cellulitis. So this is usually bacterial, risk for children. As you can see here, this is an adolescent or a child here. There's pain and conjunctivitis with blurred vision is some of the most common findings that you'll end up having with this. In addition to increased tear production, remember that those glands here that produce tears are located up in this area. So if you have this periorbital cellulitis, you're probably going to have increased tear production as well. The treatment for this situation, even though this does not necessarily look all that critical, most of the time this is going to require hospital admission and then potent IV antibiotics. So just because we're dealing with somebody's vision potentially here, they want to make sure that they have this well under wraps and that we're not just doing an oral antibiotic that potentially gets missed or something like that. So this is going to require hospital admission under most situations. So although, redness of the eye, not a good thing, they will seek hospital admission so that they can get appropriate treatment in the inpatient setting. Blood in the anterior chamber, this is known as a hyphema. So what we have here is a collection of blood in that anterior chamber of the eye, which we've talked about before. Remember, if we go back to the very beginning of the eye talk, we had both the anterior and the posterior. So we had aqueous humor in the anterior portion, and we had the vitreous humor in the posterior portion. Well, where that aqueous humor should be collecting, we now have blood. So there are some non-traumatic conditions, sickle cell disease, diabetes, tumors of the eye can cause this. It is potentially a sight-threatening condition. And any time that you have a patient that has something along these lines, obviously a referral to ophthalmology would be indicated. For our purposes in EMS, if I were to see something like this, I probably would just transport over to University Hospital or Children's Hospital, a level 1 center, knowing that they have an ophthalmologist on staff 24/7 and the patient's going to be able to get a good evaluation in a relatively short time period. Glaucoma is something that you probably have heard of. Maybe have had family members that have talked about having glaucoma or whatever. There are 4 different types of glaucoma: open angle, closed angle, congenital, and then secondary. Closed angle is the most serious, and this occurs when that angle becomes suddenly blocked, causing a significant increase in the pressure in the eyes. And that can obviously lead to potential for blindness, etc. So not a good thing. So the group of eyesight threatening conditions, it is due, no matter what the issue is, it's all an increase in pressure within the eye, or the intraocular pressure, the IOP. And that high pressure causes damage to the optic nerve, which is the second cause of blindness in the US, second leading cause of blindness in the United States. And then the blockage of flow of the aqueous humor from the anterior chamber is another reason that they end up getting that high pressure system. So the aqueous humor, that duct, ends up getting blocked. You have a sudden spike in your pressure, leading to glaucoma. So on the left side is what a normal vision would look like, and on the right side is what a patient that has glaucoma may end up seeing. So you have your central vision with the macula. All of your peripheral vision is starting to subside there. And obviously, we're able to compare these two right now and know what they're saying is not normal. But somebody that has glaucoma that's come on maybe in a short amount of time or over a period of time, they may not recognize that they have this glaucoma until they go in and then get treatment. And then once that's resolved, then all of a sudden they start to understand that they weren't seeing very well to begin with. So the difference between angle closure and open angle, the angle closure glaucoma, the outflow of aqueous humor is suddenly blocked, and that causes a rapid rise and severe increase in that intraocular pressure. And then when we are talking about somebody that has an open angle glaucoma, the intraocular pressure increases slowly over time, and then it ultimately ends up putting pressure onto that optic nerve and retina, and that is what that leading cause, or the second leading cause of blindness, is related to. This machine should look somewhat familiar to you if you've ever had an eye exam. So open angle, a lot of times there's no symptoms, but they begin to lose vision. So that's when they're going to end up seeking treatment. Like I already told you, they may not realize that they're having this issue going on because it's come on gradually, and they don't really have anything to compare it to. With angle closure glaucoma, it develops a severe pain in the affected eye. That's going to lead them to try to seek out treatment. They're going to know that they have either a decreased or a cloudy vision. They may have haloing effects around lights, those types of things. So it's probably more likely for the angle closure to seek treatment than the open angle. And then the acute angle closure treatment is to reduce the intraocular pressure, and they can do that with either medications or potential for surgery. The way they do this, as far as the eye exam, is a machine here where they actually measure the inner eye pressure. And then there's another device or machine that they can look at that they can determine if there's drainage between the iris and the cornea, and whether or not that potential space or that opening is in fact opened, or if it's closed off, causing some of those high pressures within the eye. Cataracts is another thing you're probably familiar with. It's a clouding of the lens associated with aging and related to a breakdown of proteins within the lens. Risk factors here: diabetes, eye injury, radiation exposure, exposure to ultraviolet light, so sunlight, and the treatment for this is surgery. I know many people that have gone through this, family members that have gone through and had cataracts removed. Not a big deal in today's world. I think it was a much bigger surgery in years past. In today's world, for the most part, people do pretty well with it, and it's not all that invasive. Here's another example of what that cataract may look like up close. There's another condition called optic neuritis, and this is inflammation of the optic nerve. Once again, we're not going to be able to see this through an ophthalmoscope, but if you were and you had dilated eyes, this is maybe what you would end up looking at, and this is inflammation of the optic nerve. Most of the time, these are going to be related to autoimmune diseases, multiple sclerosis. It could be a drug issue. These patients will end up having a complaint of a loss of vision, and it comes on very, very rapidly. So they'll say everything was fine, and all of a sudden, I ended up losing vision in one eye. And that is kind of indicative as far as like testing or certification exams. We would always pay attention to that. That is going to be optic neuritis until proven otherwise. They can get a loss of color vision. And they have pain with eye movement. So if you're trying to do an eye exam on these patients, in addition to the history and physical that is going on with them, it should lead you down this path pretty quickly. Vision generally returns to normal after about a 2 to 3 week period. Individuals will be placed on corticosteroids to reduce that inflammation. And then once the inflammation is gone from the optic nerve, then the patient's vision under normal conditions will return to normal. There's a central retinal artery occlusion, and then there's actually a venous occlusion as well. So this is a blockage of the small arteries that supply the retina. And most of these are going to be from atherosclerotic plaque buildup or a thrombus, common source of clots. In your patients that have diabetes, which makes very much sense because, as we know, if we have an elevated hemoglobin A1C, the blood has sugar in it, quite literally. So that sugar is very sticky, and these vessels are very, very tiny. And that is why eye issues are always one of the things that we worry about with diabetics, is because these vessels are going to end up being blocked by that sticky, sugary blood, and then the patients are going to end up having difficulty with their vision because they have the central retinal artery occlusion. Some of the symptoms here can involve all or part of one eye and last for a few seconds to a few minutes, and the blockage can be permanent. The treatment is going to be a fibrinolytic and then massaging the eye. So with fibrinolytic therapy, this is something that they will give them in an emergency department after a consultation with an ophthalmologist to try to break up some of those clots that have been formed. I told you that there's a central retinal vein occlusion, and this is similar to that. It's just basically a blockage of the small veins that drain the retina, caused by a thrombus or atherosclerosis, just like the arterial occlusion is. Common in diabetics, hypertensive patients, etc. And those individuals are going to tell you that they have blurring or a loss of vision. And most of the time, this will come back without treatment, although completely normal vision rarely returns. So they are able to see, but it may not be what they were seeing normally prior to the condition occurring. Retinal detachment, and I have another picture here in just a second that'll be a little bit easier maybe for you to see exactly what's going on, but this is a separation of the retina from the supporting structures. A lot of times this is due to an unknown cause. It can just happen spontaneously, but it does happen in trauma as well. Diabetics, once again, high likelihood of having issues with their eyes. Bright flashes of light in the peripheral vision is one of the indications where people will say that they need to be seen, and then that is where the determination comes in that this is a retinal detachment situation. And they will also tell you that they have those floaters in the eye. So this is kind of what it looks like from another perspective here. Here's where the detached retina is on this far right, and this is what it should look like under a normal condition or in a healthy eye. So they'll end up getting a shadow or blindness on part of the vision that is in that affected eye, and this is going to end up being treated surgically. Once again, I personally know some people that have had a retinal detachment and have done well after they went back in and had the surgical procedure to reattach it. All right, moving into the ear, there's a few things that we should talk about with the ear. The external ear, the pinna. We'll look at this a little bit more. I'm going to go back here for just a second. The pinna is what is responsible for collecting the sound waves and directing the sound into that external canal. So if we look on this screen here, here is your pinna, also known as the auricle, and that is what is responsible for kind of pulling that sound in and then directing it to that external auditory canal or the inside of the ear as we may think of it. So the external auditory canal extends to the tympanic membrane. I'll show you what that looks like here in just a second. And that canal contains a protective substance called cerumen, or more commonly and affectionately known as earwax. So here's our pinna, or the auricle. Here's the external auditory canal. We know that we have cerumen in there, or earwax, to protect the ear. And it travels all the way down until we end up having this tympanic membrane. So if you go into the doctor, you take your kids into the doctor for an ear infection, and they look at your ear, what they're looking at here is they're actually trying to find the TM, or the tympanic membrane, to see if it is a bulging tympanic membrane, telling us that there's some sort of fluid or infection, maybe behind here, in which case the patient would have an otitis media, or inner ear infection, versus something on the external portion, or the outside of the tympanic membrane, which would be relative to an otitis externa, is what we would refer to that. So semicircular canals, round window, oval window, the vestibule. So all of this area up here, the semicircular canals, are what are responsible for basically your balance. So if you end up getting fluid, or these things get off a little bit, this is where vertigo, Meniere's disease, those types of things, they're affecting these semicircular canals. We do not want anything to affect those. Otherwise, it makes us very dizzy. It will make us very nauseated. We will have vomiting, so on and so forth. Foreign body in the external auditory canal is not an uncommon thing. So this is what it would look like if you were to put a scope into someone's ear. And actually what you're looking at here are actually insects in the ear, and that is a very common thing, believe it or not. So it is not uncommon at all for insects to be in there. The insects make up for about 14% of things that are put into the ear as far as foreign bodies. And of the insects that are in the ear, believe this or not, about 80% are cockroaches. So if that makes you kind of queasy, or not want to put your head on something at night, then I can certainly understand where you would be coming from. But cockroaches is one of the most commonly found things found in the external auditory canal, and then ultimately removed in an emergency department. So they can be painful, they can bleed. There's other things that can cause infection there. So there's a lot of different things that go on, but it's not uncommon at all, and especially with kids or your pediatric patients, to put foreign bodies in there. But if it's not something that has been placed in there, chances are it's probably an insect. All right, so it can be difficult to remove these cerumen impactions, or foreign bodies in the ear. If they do have a cerumen impaction, there is a way that you can do that. Any of your urgent care, certainly, I don't think that this warrants an emergency department visit, but your primary care provider and urgent care, they should be able to get these cerumen impactions out for the most part, and if not, then maybe follow up with an ENT. But you can put mineral oil, and it will help to loosen the cerumen there. If it is an earwax blockage, if it is a foreign body and you have an insect in there, the mineral oil can help to suffocate that insect, and then you can end up having that drained out or cleaned out in an urgent care setting, etc. This is what impacted cerumen looks like. So if you were to look through a scope into somebody's external ear, you may end up seeing something that looks like this. It obviously gets very dark, and it is there to trap foreign bodies basically from getting into the inside of the ear. And that's why we always say that having some earwax is actually a really good thing. You don't want it to all be gone. But a lot of times, and a lot of people do use Q-tips, et cetera, to try to keep their ears cleaned. Although just kind of keeping in mind that the cerumen is something that is meant to be there naturally. So if you end up getting a cerumen impaction, the patient may end up telling you that they've had a sudden loss in their hearing, and one side would be more common than the other. It would be pretty rare to have a bilateral cerumen impaction. But certainly you could, I guess. An earache, maybe ear plugging, tinnitus or ringing in the ears, and then hearing loss would be another thing, and probably the most common thing that people would tell you. Once the plug is removed, hopefully the tinnitus and the hearing loss goes away, and you can do that with mineral or baby oil. There are drops that are out there, hydrogen peroxide, etc. Or you could use a warm fluid. I would not do this unless you're trained to do it, because if you put cold fluid in the ear, it actually can make you very, very and violently ill. Other infections that can be commonly found, this is that otitis externa, commonly referred to as swimmer's ear. This is where you get an inflammation in the external auditory canal. The symptoms here are going to be pain, drainage or itching of the ear canal, and maybe even some hearing loss. And if you take the ear and kind of pull down at the tragus of the ear, it will elicit a pain response in the individual. That's one of the clinical findings of somebody actually having an otitis externa, is if you can kind of reproduce or increase the pain with external stimulation. Otitis media is very common, especially in children, and this can be from the blockage of a eustachian tube. And as I told you, what we're going to look for when we put a scope in, we're trying to find the tympanic membrane, and you can kind of see here that this is reddened. It doesn't look like it's very happy. And you can see a bulging tympanic membrane. That tells us that there's pressure on the opposite side. So things are starting to push out towards us, and you can see that there's some inflammation. So that would tell us that they have an otitis media, and antibiotic treatment is going to be one of the things that they would end up being put on. Can be bacterial or viral in nature. And most of the time, they're just not going to feel well. They're going to have an earache for sure, a general feeling of malaise. They just don't want to do too much right now. And it can actually come with fever, vomiting, and diarrhea. And that's just from the infectious process that is going on as well. If you were to look into somebody's ear, which I don't recommend you do unless you've been trained to do that, because you run the risk of rupturing their tympanic membrane, this is what a ruptured tympanic membrane would look like. So it should be kind of this white, waxy appearance, and this is what a normal TM should be, with the exception of this rupture down here, kind of your 4 to 6 o'clock position, if you will. So it is a very delicate structure, and it separates that external ear from the middle ear, and it can be easily perforated or ruptured by trauma, an increase in pressure, any type of blast injury, something like that. When that happens, the patient will have decreased hearing, earache, and drainage of blood or pus, and it is going to be an extremely painful situation for the individual. So think about administering some pain medication under your pain protocol that you would be following under normal conditions. Mastoiditis is an infection of the mastoid bone at the base of the skull. Primarily affects children as well. This is an example of what mastoiditis might look like. It's in this posterior auricular, kind of behind the ear. Ear pain, drainage, hearing loss. There's going to be erythema, which you can see that's just that reddened, unfriendly kind of look, and tenderness over the mastoid bone, and antibiotics. And then if antibiotics don't work, then they actually have to go in there surgically and clean that up. But that is what mastoiditis would look like. And again, it's found commonly in children. Labyrinthitis, these will be some of the sickest patients that you will ever take care of, and they're not really all that sick. They will appear sick, they will be diaphoretic, they will be vomiting, they will appear there's something majorly going on with them, or maybe even like a cerebellar stroke. That's how those individuals will present. A lot of times because they're going to be very, very dizzy, have no balance, etc. A lot of vomiting, a lot of nausea, but it is simply just something that is going on here with inside their inner ear. Once they get medications and they can treat that, their sickness will go away pretty much as quickly as it came on. So it's an inflammation of the inner ear, also known as labyrinthitis, oftentimes following an ear infection or maybe an upper respiratory type infection, where that bacteria basically just kind of transgresses up into the round window and the other portions of the inner ear. So vertigo, involuntary eye movements, which is known as nystagmus, dizziness, loss of balance, etc. And then the treatment is basically going to be symptomatic treatment. You got to get rid of the dizziness. You got to get rid of the vertigo. So some medications, and this is going to require a visit. They're not going to probably want to call this in over the phone or send it in without being seen. But benzodiazepines will actually work very well in this situation, and then they can put them on medications like meclizine, those types of things as far as their dizziness is concerned. Meniere's disease, inner ear, affects the balance and the hearing, and the labyrinths within that inner ear become swollen. No known cure for getting rid of this. Signs and symptoms, it begins acutely. They will have severe vertigo and dizziness, severe nausea and vomiting, and hearing loss is unilateral. So it is a chronic inner ear disorder that causes vertigo. Most of the time, people that end up getting diagnosed with Meniere's disease, it happens between the ages of 40 and 60, but it can develop at any age. And from those that suffer from it, they tell you that it is absolutely terrible. Nasal anatomy here. Couple things really. The nasal portion of the lecture is pretty limited, so I'm not going to go over all the different anatomy here. I know we do this quite a bit when we talk about airway, and in particular the placement of a nasopharyngeal airway, or maybe an endotracheal tube if we're going to do a nasotracheal intubation. So I'm not going to cover it again today, because really there's only a couple different things that we're going to talk about with regards to the nose, and that's going to end up being nosebleeds. So the structures within the nose are highly vascular. There's a makeup of the nose that's called Kieselbach's plexus, and that is responsible for about 90% of the nosebleeds that patients will end up receiving. You can tell this if you end up looking at this visually. You're able to see that Kieselbach's plexus has been disrupted, and most of the time that's going to be from nasal picking. The sinuses are air-filled cavities separated from the nasal cavity by the mucous membranes, and we'll just take a quick peek here at what the sinus anatomy looks like. So we know that all of these different sinuses exist: the sphenoid, frontal, ethmoid, maxillary sinuses. And if you are wondering if somebody has like a sinusitis or something along those lines, head cold stuffiness, if you just gently tap over like the sphenoid or the maxillary sinuses, it will elicit a pain response in the individual, telling you that there's probably some inflammation there and they probably have a sinus infection. That is why the providers would tap on your face if you go in there with something that would be consistent with a sinus infection. So with an epistaxis or a nosebleed, secondary to minor irritation, or maybe from an upper respiratory infection, most of the time not going to be life-threatening, although posterior nosebleeds can be, especially if somebody is on anticoagulant type therapy. Anterior bleeds are going to be from Kieselbach's plexus, as we've talked about, and those posterior nosebleeds from the blood vessels further back in the nasal cavity. The treatment, most of the time, it's going to just be simple procedures, as you guys are already aware of. Simple pressure. There are medications that can be used. One of the medications, and probably kind of at the top of the line in an emergency department, is actually liquid cocaine. So as we know, cocaine is a potent vasoconstrictor. And when we're talking liquid cocaine in an emergency department, it is legitimately cocaine. So they can get it from pharmacy, and then they'll just kind of brush it into the area that is bleeding, and it'll help to constrict the vessels. They can also use cauterization tools catheters, nasal tampons. This is an example of a nasal tampon where they will insert the nasal tampon and then they blow it up and it puts pressure onto the bleeding vessel in hopes that the bleeding will soon stop. Patients may have a little bit of pain and nausea. If they have the nausea and vomiting, that's probably related more to the swallowing of blood than anything else. So it's just a matter of getting the bleeding to stop and having the patient stop swallowing blood, and hopefully the nausea and vomiting will go away. Foreign body into the nose, common, kind of like the ear, especially in the pediatric patient. They will take things and put them up into their nose. So toys, beads, small rocks, food items, etc. You can kind of see the candy corn here being flushed out in this illustration. One of the ways that you'll be able to tell is going to be a whistling with respiration. So when the patient breathes in through their nose, you're going to end up hearing that breathes in or breathes out through their nose. It's going to be a whistling sound because there is an obstruction there. The treatment is going to be removal of foreign body. If you can see it in the pre-hospital setting, I think it's probably appropriate to try to get it out. If you're not able to see it, I would not go digging in there. Even in the ED, they don't have great instrumentation. They may end up having to call an ENT physician in to remove the tools that the ENT folks use are incredible, very, very tiny. So if you're not comfortable or not sure that you're going to be able to get what the foreign body is, I would just leave it alone unless it's causing you a problem and transport it and let someone else kind of take the time to remove that. Rhinitis and sinusitis. This is inflammation of the nose. Upper respiratory infection is a common cause. Allergies, so an allergic rhinitis. Similar conditions to that would be very, very common. All of us have probably had rhinitis at some point. In infants, we're going to treat this with humidified air, saline drops, and then bulb suctioning. And then we may end up considering some nasal decongestants, antihistamines, and nasal corticosteroids. That would not necessarily be the case in the younger population, but certainly as they get older and into adulthood, a lot of people do take the nasal decongestants and nasal corticosteroids on a regular basis, although it is recommended that you don't do that too routinely because there can be some side effects from it. With sinusitis, infection or inflammation of the sinuses, bacterial, viral, or allergies can cause that. Remember, we talked about facial pressures, and you can just simply tap over where the sinuses are at. And if it elicits a pain response, then you probably have an inflammation of the sinuses themselves. Most of the time, they're not going to do too much for these, although they can put antibiotic therapy, decongestants, some antihistamines, and corticosteroids to relieve some of the inflammation. And over a couple of days, the patient will start to feel better. All right, the tongue, as far as taste, cranial nerve number 9 and number 7. The cranial nerve number 9 is the posterior 1/3, and that is responsible for your sour and bitter. And then the anterior portion of the tongue is salty and sweet, and that is the anterior 2/3 of the tongue, and that is managed by cranial nerve number 7. With pharyngitis and tonsillitis, I think anybody that would look into the back of the throat, they could see this. They can see that it is reddened. It is inflamed. So that is an example of pharyngitis. An infection of the pharynx, infection of the tonsils themselves is tonsillitis. It can be either a bacterial or a viral cause. They'll have a red and swollen throat. An enlargement and tenderness of the anterior nodes. And remember, this is all related to drainage and trying to get all of the bad stuff out. So patients will have headache, neck pain, those types of things. And you'll oftentimes be able to feel the inflamed lymph nodes within the anterior portion of the neck, which is why if you go in for a well child or a well adult visit, or if you go in with a sore throat or an earache, something along those lines, are always trying to press around on those lymph nodes. Here's an example again of pharyngitis or strep throat, as we would commonly refer to this as, and you can kind of see the white patches. So this is a bacterial infection. That's what strep throat would look like, in which case you should put the patient on antibiotics or take them to appropriate care, take them to the primary care physician or an urgent care to where they can get antibiotic therapy started pretty quickly. Another one that's pretty easily identified and recognizable is oral thrush. This is a fungal infection of the mouth. Infants and diabetics with poor glucose control, your patients with HIV or AIDS, and side effect to antibiotics. Remember that we have normal microflora that kind of grows into the mouth, into the vaginal canal. Those areas. So if we put patients on antibiotics and it gets rid of those normal microflora, it allows the ability of the fungus to proliferate, which is what thrush is. Or if we're talking about in a female population, a yeast infection. So that is most of the time going to be caused because of an antibiotic that they are on. Not a big deal. They just have to continue taking that antibiotic and then treat for the fungal infection. Or most of the time, what they would do is stop that antibiotic and place them onto a different antibiotic. And then the patient would just need to know that, hey, the last time I was on this antibiotic, I ended up getting thrush. Can you put me on something different? And most of the time, that's what's going to end up happening in that situation. Peritonsillar abscesses is another thing that we should be concerned with. And I'm not going to go into great detail here. So peri just means around, and then tonsillar. So peritonsillar abscess, if these rupture, you should be concerned about excessive bleeding and potential for airway control issues. That is why I leave these in here and bring these up. If you get dispatched to somebody that had a surgery from a peritonsillar abscess and it's now bleeding, just understand that you may be up against a little bit of a wall when we're talking about airway management. Another thing that we should be concerned with here is something known as Ludwig's angina. This is an oral bacterial cellulitis. So inflammation on the floor of the mouth under the tongue. So this is what Ludwig's angina is. They love to ask these questions on certification exams. So if you ever see this, just know that it's going to be an airway concern. Most of the time, these are going to develop after they've had like a dental abscess or some sort of a mouth injury. So these are going to come on very quickly. The swelling can occlude the airway, and it can be a life-threatening situation. So just like anything else that we would worry about with the oral cavity, it's always going to be airway, airway, airway. Here's another example of this. In severe cases, you can see Ludwig's angina. You can see the tongue, and then you can see the amount of swelling underneath the tongue, indicative of Ludwig's angina. This is going to be a very difficult patient to get an airway on. So I would recommend that you transport swiftly. If you have to try to get an airway in the field, good luck. If you can call ahead of time and let them know that you're bringing a patient in with a suspected Ludwig's angina, hopefully they can get anesthesia even into the ER, because the ER docs are probably not going to want to have to do this alone. This may be a situation where you're thinking of a surgical airway if you're in a position where you cannot intubate and you cannot ventilate. So remember, in order to do any type of surgical procedure, surgical airway, we should have both, not intubatable and not ventilatable. So if you have both of those, then, you know, any port in a storm. But if you're able to manage this person's airway and get them to an appropriate center before doing any type of surgical airway, that would be the best. Dentalgia and dental abscess, most of the time these are going to be a result of a lack of preventative care. Non-life-threatening emergencies, although they are going to be very, very painful, and that is what dental pain is dentalgia. Exterior of tooth breakdown, allowing sensitive interior structures of the nerves to be exposed. These patients are not going to be very happy, although you didn't necessarily do anything, but they are going to be in quite a bit of pain. So if you can transport them and get them some dental care, that's probably good for the patient. Depending on where you take them, probably not going to do too much for them overnight or over the weekend. It's going to be more pain management and then getting them in to see somebody on Monday morning. Foreign body airway obstruction located in the mouth or the throat can obstruct the airway. At risk, kids, obviously, psych patients and prisoners, patients who do not have natural teeth. We should ensure a proper airway, transport to a facility where the foreign body can be removed, and that should really be in any emergency department. But if we can use our McGill forceps there and remove the foreign body, then certainly we may need to do that. If they're obviously able to breathe on their own, then there's no need to try to remove it at this point. It's in the event the patient is not able to breathe that we really should have cause for concern in the pre-hospital setting. Epiglottitis is inflammation or an infection of the epiglottis. This is going to be a life-threatening or potentially life-threatening situation. Fever, sore throat, and drooling. So the drooling, they're going to sit in a tripod position. They'll be drooling. Most of the time, you're going to get information about them having stridor, or you're going to hear stridor audibly. These are not good indications. It's always going to be an upper airway obstruction. And what we're going to have to do is try to transport the patient as calmly as we can. We don't want to take their airway from them, protect their airway as best we can, and then ultimately antibiotic therapy is what they are going to need. Laryngitis is the final thing that we will talk about here under the ENT portion. This is going to be a swelling and inflammation of the larynx. Viral infection or a drainage from the upper airway or sinus infection. So if you're looking here, these are healthy vocal cords. And then at the bottom is what the inflamed vocal cords would look like. And obviously that's not a real picture, but they will be red like that. They will be inflamed. It should be pretty obvious for you to see. Although you probably are not necessarily intubating somebody or being able to look at that unless they have an airway or another type of issue going on. We would not normally be just looking at laryngitis. So allergies, bacterial infections, GERD, etc., in patients that are suffering from laryngitis, fever, hoarseness, or a loss of voice is what the clinical indications are going to be. Most of us have probably had laryngitis at some point, and most of the time it's going to end up going away after a week or 10 days, something along those lines.